Our Big Innovation Conversations are a series of monthly discussions that showcase innovations and solutions which improve health and care. Here at the Innovation Agency, we classify innovations and solutions into categories and themes which reflect the transformation and the redesign challenges that we're all facing together as our health and care system becomes more integrated. To support a culture that helps system transformation and improves care and safety through the adoption of those innovations. In addition to this, we also work with our local health and social care system to improve patient safety through the adoption and spread of proven patient safety innovations and the delivery of our local patient safety collaborative, which is one of 15 collaboratives which forms a national network for safety improvement. Main areas of focus currently relates to improvement of care and safety in care homes in relation to the recognition and response to deterioration. And today's conversation will therefore focus on how we can achieve this. Hear from Jane Mastin, who's a public health nurse leading on infection prevention and control in Lancashire County Council. A particular interest in sepsis and will tell us about a practical example of how News 2 has been successfully implemented in care homes. Later on, we're then going to hear from Matt Inardikin. Matt is a consultant in acute medicine and is a clinical lead for sepsis and deterioration in the Wessex Patient Safety Collaborative. He's also the national clinical lead for deterioration with NHS England and NHS Improvement. And the focus of Matt's presentation today is on Restore 2, which I'm hoping some of you may have heard of, and it's a tool which takes a holistic approach to the identification and management of deterioration within care homes. Before we start, you'll see that we do have a chat box available, so please do put any questions that you have into the chat box, but please make sure that you send the question to all attendees, not just to the host, so we can all see what's being asked. And we are going to aim to answer questions after each speaker has finished their talk. Just to mention for housekeeping, everyone on the call today has been put on mute automatically as they enter the webinar. Just to say thank you to you all for taking time out of your busy schedules to join today's session. And I'm now going to hand over to Jane, Lancashire County Council, for her presentation.
Thanks, Andrew. Jane, bear with me. Let me just share your slides. Okay, Jane, you should be able to share your slides now. Yeah, okay, they're on our screen. Great. Thank you.
Okay. Hello, everyone. My name is Jane Mastin. I'll take you through the sepsis strategy for Lancashire care homes and the work that we've been undertaking since 2017 to identify and manage sepsis in our care homes by the use of News 2. So the aim of the strategy is to improve sepsis-related outcomes and experiences for care home residents across Lancashire. So the content of my presentation will focus on why this work is important, what our key drivers were, what has been delivered, what are the outcomes, and where are we now. So the work started during 2016. We undertake post-infection reviews for MRSA and C. diff, and during these post-infection reviews, I noticed some consistent themes in relation to those MRSA and C. diff cases that developed into sepsis. And these were that there was a lack of consistent approach to the early identification of suspected sepsis cases, that there were delays in escalation and hospital transfers for time-critical healthcare, and that when residents were transferred following delay, this led to more intensive hospital treatment being required, sometimes led to poor outcomes for the residents themselves. So following on from this, I undertook some semi-structured interviews with home staff and district nurses who told us that sepsis was an issue of quality which needed to be addressed. There was at that time lack of best practice local sepsis for home staff, and there was a lack of consistent approaches to the early identification and timely transfer for treatment. So during 2017, I worked with CCG to see if there were sepsis training packages going to be delivered across the county, and there were none. And following that, that's when I then developed the training course itself. Throughout the course of this work, we've also received complaints from who have asked why hasn't sepsis been identified earlier in care homes and out in the community. So if you look at the 6 dimensions for quality healthcare, we were presented with some challenges at that time. So our key local drivers here in Lancashire are that we have over 400 care homes, and these are made up of approximately 300 elderly care providers and 100 learning disability providers. Our care home residents represent a high-risk group for sepsis in that they are elderly, frail, with long-term conditions and comorbidities, and that they are prone to infections. And we know from working with our care home staff and from the reports that our care home staff have to submit that urinary tract infections and respiratory infections are two of the most common causes of sepsis in our two of the most common causes of infection in our care home, which lead to sepsis, followed by skin infections such as cellulitis and pressure sores. So there was a real need to increase the capability and capacity at the beginning of the resident care pathway in our care homes for appropriate identification, escalation and time-critical health. So the key national driver that underpinned the work really was the National Confidential Inquiry into Patient Outcome and Death. This is a review of deaths from sepsis, and at the back of the document it provides 21 key recommendations for across the healthcare system, both primary and through to secondary care. And 6 of those recommendations I felt were relevant for the community and particularly relevant to care homes. So running through those, we need to ensure that there's robust safety netting for those suspected at risk of sepsis. We need a standard method of referral from primary through to secondary care, and an early warning score such as NEWS should be used for the community into secondary care. And the training and recognition in the management of sepsis is required, as well as early identification and management of the source of sepsis wherever possible. And patient and carer information is important in order to continue to raise awareness of sepsis out in the community. So what has been delivered? Well, as I've said, at the beginning of the process, I undertook a great deal of research on our key drivers with a range of key partners. And following this, I had a meeting with 6 of our CCGs across the county, the North West Ambulance Service, sepsis attended. And at that meeting, we gained consensus to develop a sepsis strategy and also to develop a training programme. The sepsis strategy was then developed and consulted on with key stakeholders and was launched in July 2017. The training programme started in September 2017 and has been embedded annually since then. And we're currently delivering the sepsis programme April 2019 to March 2020, and I deliver that in collaboration with Lancashire Teaching Hospital's sepsis critical care team. The aim really, on a year-by-year basis, is to train a minimum of 100 staff from care homes across the country per annum, and at the moment we're on course to do that, as well as exceed that target. And the idea is that care home staff attend an initial training course, and then they cascade train out in their care homes, or they can send more people to the training course itself. So we have a combination of training approaches for them. So the objectives for the training are threefold really. care home staff following the training will understand the importance for preventing infections and good infection management practices. They will have increased knowledge of sepsis and be knowledgeable, confident and skilled to detect, manage and appropriately escalate residents with suspected sepsis for time-critical healthcare. So in essence, we're training staff to use their clinical judgment, observe and report the signs of infection, observe and report the soft signs of sepsis, as well as provide a News 2 score. We'll also learn about post-sepsis syndrome on the course, and I feel that whilst we need to raise awareness of sepsis deterioration, we also need to continue to raise awareness of sepsis syndrome, and we find that little is known about that at the moment out in our communities. We still have a lot of work to do to promote knowledge, understanding and care of sepsis syndrome. And following the course again, staff will also be able to raise public and professional awareness of sepsis within our care homes. So in a sense, this slide, which was given to me courtesy of Matt in Ardwick, essentially sums up what we're asking care staff to do. So to use their clinical care and judgment, to suspect and report infections, to suspect sepsis, and to provide a news score to either GPs, advanced nurse practitioners, or NWAS when they're called 111. And the escalation for this is that if anyone scores an aggregated news score of 5 and above, that they are transferred to hospital for critical health care. So just to run you through the training then, the training started in September, as I've already said, and I piloted 2 training courses with 30 staff from 5 CCGs across the county. And it was at this point that I ran a PD cycle on the training. And care staff reported back that they wanted a safe space within which to use the equipment to undertake News 2, to practice doing News 2, to practice using case studies. So that's some learning that I'd particularly like to share if anyone's interested in setting up with care home staff, that they, if they haven't taken observations or undertaken News 2 before, they really do value a safe space within which to practice using the equipment, aggregating the scores accurately, and using case studies to practice applying News 2. So since February 2018 to date, as of last week, we've delivered 21 training sessions to now 260 care staff. And the feedback from staff is very positive. As you can see on the screen, they're really enjoying the training sessions that they're attending and implementing the learning once they're back in their care home. The slide also shows that staff have actually attended from over 9 CCGs across the county and into our borders. So that includes CCGs in our ICS area, as well as some on the borders of ICS. So what are the outcomes? Well, we're having some fantastic feedback from care staff following the training, and it's great to receive this from them. So, and these are kind of categorised here in themes. So care home staff are telling us that infections are being treated earlier in care homes with less ambulance call-outs and hospital admissions, that residents feel reassured that they have normal News 2, and if not, something will be done about it. And families like to see immediate response to residents if they deteriorate from the care staff. We know that residents with suspected sepsis are being identified earlier and are receiving prompt transfers of care now, and that there is a more detailed communication being provided from home staff to our GPs, to NWAS, and to the hospitals at handover. And care staff are feeling more empowered, confident and skilled to suspect sepsis and escalate residents for time-critical health care. So part of the training includes the importance of identifying those residents which can best be cared for in the care homes and those which are appropriate for hospital admission. What we want to avoid is in a hospital admission, particularly if residents have expressed a wish to not go into hospital for care and receive acute treatment. So we talk at length about the importance of making that distinction really between those care home residents with whom it's important who stay at home versus those that are transferred into hospital. And I've got a couple of case studies here from care home staff whereby, for example, situation one, a 62-year-old lady with schizophrenia, based on a score of 3, had strong smelling urine with new mild confusion, and at the point of deterioration, her new score was 5. The care home staff called the GP who attended, and she was prescribed nitrofurantoin, given fluids, was nursed in bed, and her NEWS 2 score reduced, and that lady was able to stay in the home. The care staff didn't really want that lady to go into hospital because of her mental health condition, and they felt pretty pleased that she was able to be nursed successfully. But the safety net of knowing that if her NEWS 2 score went above, they would transfer her into hospital via ambulance. And then the second is an 81-year-old gentleman with multiple comorbidities, frail with a catheter, who became unwell and twitchy. His NEWS 2 score was 3, so that was a single parameter score. But the care homes were concerned about this gentleman, and he had a DNAR in place. Sorry, he didn't have a DNAR in place, and he wanted to be treated. And so the care home staff were able to express their concern about this gentleman, and he was transferred to hospital and treated successfully with IV antibiotics for urosepsis and was returned home poorly, frailer, but he was his old self. So then in terms of escalation, these are 2 examples here of where care staff have used NEWS in collaboration with GPs and ambulance staff to show how staff have gone on to escalate. So the first one is a 73-year-old gentleman who currently lives in a residential home. He has dementia, possibly Parkinson's disease. He fell during the night and became acutely unwell, and this gentleman's previously had urosepsis twice. NWAS was called, our Northwest Ambulance Service, and urosepsis was suspected again. And one of the care staff went with this gentleman to hospital, and she actually had a discussion in the ED with the staff, saying that she'd been trained in NEWS 2, that they'd suspected sepsis, and they discussed about the importance of the golden hour and the sepsis 6 bundle being given. And this gentleman was, again, successfully treated and returned to home. And then another case where a 73-year-old lady with osteoarthritis, osteoporosis, hypertension, asthma and heart failure was very poorly with a NEWS 2 score of 13. She was transferred again via ambulance, treated with the antibiotics for sepsis due to cellulitis and UTI, and again she was successfully transferred home. So a few examples, staff have been able to make the distinction between the elderly in the home and also those that have been transferred to hospital. So where are we now? We continue to deliver the training sessions. Are encouraged to attend an initial session followed by a training session 3 months later. They're encouraged to take monthly baseline news to on their residence baseline so that they can compare that with the News 2 score at the point of. I've just been going around quite a lot of the care homes that have been trained during 2017 up to March 2019 to find out how implementation is going out in the care homes in relation to News 2. And I've also just, I'm also in the middle of carrying out an online survey as well. So particularly in relation to them using News 2, this is what the care home staff are saying really, that it gives them reassurance about how well or unwell a resident is with a complex physiology. This is particularly the case for care home providers who are taking care of people with dementia and also those who have learning disabilities. Care home staff also say that it gives them confidence when escalating a resident to a GP or MWAS. That News 2 helps them to monitor a resident whilst they're waiting for GP. And care home staff are having discussions with GPs, as you've seen in the previous case study, about where the best place of care is for a particular resident. And some of our care home staff, particularly residential staff, will take News 2 measurements and communicate this to Telemed, who will aggregate the score and make a decision whether the GP is called or MWAS is called. And if you were to ask me what makes this kind of work successful out in the care homes, I would say from going out and meeting the care home staff that what makes to whether all of this work is implemented or not are 3 qualities, and those qualities I think are leadership, and that can be at any level from senior level, deputy manager level, manager level. Those that have passion, they really want to learn about how to do News 2 and apply it in care homes, and those that are committed to doing it, those that are committed to carrying on doing the monthly News 2 scores on the residents to establish a baseline and also to compare at the point of deterioration. So that's what I've witnessed really from going out and speaking with them, that it's those 3 qualities that can make a difference as to whether this work is embedded in a care home or not. So since May 2019, I've actually been rolling out Restore 2, which is a comprehensive tool now available to help home staff identify the early signs of deterioration, take News 2 scores, escalate appropriately. So we've started implementing that here in Lancashire, and the feedback from care home staff is that they really, really like it. I'm not going to say any more about News Restore 2 because Matty Narder-Kim is going to talk about it at length. So that really ends my presentation for the webinar today. Thank you.
Jane, Ian, would you like to ask any questions or manage the chat?
Thank you very, very much, Phil. And thank you, Jane. I think that was a very, very interesting presentation. I think the slides were particularly clear and the points that you were making were absolutely fantastic. I think, first off, just for people who are listening to the chat, we have the chat box for questions. And so if anybody has questions they wish to ask them, please use that. We have a couple of minutes just at the moment. And just from my standpoint, just taking a couple of minutes out, Jane, what would you say are the sort of challenges that you faced, and how did you sort of address those challenges in taking the project forward?
So the challenge initially was the number of care home staff who wanted to attend training. So the training sessions are run on a monthly basis, and the number of staff that wanted to attend outweighed the number of training sessions that are made available. So I had to increase the number of training sessions. The second challenge is that not everybody that registers for a course will attend, and that can be about workforce pressures within the care homes themselves. So, you know, shortage of staff, people phoning in sick, for example. So that has to be managed. And then following training, I would say that one of the challenges at care home staff is the turnover of staff. So sometimes I will train staff and they will then go back to the care home, but sometimes they leave, and that then means that the capability and the systems aren't established in the care home. So that can be one of the big challenges, actually. Yeah.
Indeed. You mentioned obviously the case studies, which I think were particularly powerful, and you mentioned some of the feedback that you've received. Are there any specific points of feedback that you think need amplifying just for their importance in terms of the overall project itself?
I think that it's really important that we work with our care home staff to help them to prevent infections in the first place. And when they do experience infections in a care home, that they build a culture in their care home of reporting deterioration or infections early, delay that, and that delays in the system, you know, are shortened really. So I would say they're kind of key messages. I think another message is that home staff are really open to being trained to identify and manage sepsis well. They're very keen, they're very positive about it, and that includes both residential staff. Some of my keenest staff in terms of implementing this work have actually been from residential care homes.
Phil, are there any questions within the in the Q&A box, the chat box? I'm not able to view it just at the moment.
There are, yeah, there's 5 in there. Can you not see it?
No, I can't.
And I can't see it either.
Okay, bear with me a second. The webinar is just, I'm getting the blue circle of death, so when that goes, I'll try and find it for you. Good timing, isn't it? Bear with me. Yeah, it's still frozen for me, so yeah, just give me a second. I'll let it sort itself out, and I'll.
Okay. If people can just bear with us for a moment while we try and get access to the questions, that'd be very helpful. Thank you. Return to those, Phil, and maybe ask Matt now to begin his presentation.
We can't, Ian, unfortunately, because WebEx has crashed on it. Oh, wait, no, it's back. Maybe, possibly. Is it back? Yeah, unfortunately, my computer's had a bit of a problem. Hold on. Okay. Okay, so questions that have come through. Can you see them? Apologies for this. Okay, so I can see them now. So there's a question here from Chris Richmond that says, is the training mandatory and included as a requirement of contract? Given that 200 plus staff are trained, there has been an issue releasing staff stroke on-day dropouts of courses. Are the courses delivered in-house or at a central venue?
So the training isn't currently mandated. Staff can opt into the training.
Okay.
They currently come to a central venue in Bristol, but I'm looking to now also train out in localities with neighbourhood teams to improve access and support following training.
Okay, thank you. From Liz Williams, is there further sepsis training available for staff in care homes? Please, could you provide details if you have any?
Yes, we're shortly going to release the training programme for next year. All the courses for this year are completely full. I think there's still some places in December, but in October the courses for next year will be released.
Okay, so the question here is the equipment for taking news to purchased by the care home or supplied to them as part of this initiative?
The care homes buy the equipment themselves.
Okay, thank you. Do you add this into induction training for new staff?
It's not mandated, and so care homes decide who comes from the care home. So what we say is that we ask managers, deputy managers, nurses and senior carers to attend. It's not part mandated inductory training.
Okay, thank you. And then the final question we've got here for you, Jane, is how difficult was it to get the care homes on board to undertake the News 2 SCRE, News 2 score, sorry. This is an area we're having difficulty with, care home managers reluctant to undertake the assessments required for News 2.
On the whole, our care home staff have been very positive. There are some residential care homes who don't want to do it. You know, they don't feel comfortable, they don't feel confident, they're concerned about doing it, and so they opt not to do it. But that's why Restore 2 is a really good tool, because care home staff can identify the soft signs of deterioration, and then other healthcare professionals can take News 2 scores. Because Restore 2, they do have the SBARD system, so they can describe fully the resident's condition and their condition at the point of deterioration.
Okay, thank you, Jane. That's all the questions we've got for you from the chat box. Ian, do you want to go there?
Thank you.
Online, so.
Thank you very much, Phil. Apologies there for those technical glitches. Jane, thank you once again for the presentation and those very clear answers. And that's been really useful, really helpful. Thanks again. I think now it's time for us to hand over to our second presenter, and that's Matt Inard-Kim. He's going to tell us some more about, as the reference there at the answer to the final question, about the Restore 2 system. So I'll hand over now to Matt. Thank you very much.
Thank you, Ian. Again, unfortunately, some technical issues, just trying to get Matt back on the call. Seems to have lost the ability to unmute him, so just bear with us a second. Again, apologies, just having an issue, just unmuting Matt, so just bear with us a second. Thank you. Matt, if you can hear me, could you try calling again, please? Because it's the reason the system isn't registering you as being on the call. I can see your name, but I can't see any option to unmute you. Thank you. Hi, Matt. You there?
Hi, can you hear me?
Yeah, we can now. Great. Thank you. Thank you for holding on.
Lovely. I can't see slides yet.
Yeah, your slides are on now. I'll just put them on.
Lovely.
Ian, are you there?
Indeed. Okay, just a very quick intro. Can I just now hand over to Matt Inard-Kim, who's going to take us through some issues around Restore 2, and over to you, Matt.
Hello, everyone. And I've spent my...
Sorry, Matt, we can't hear you. Hello, it's not a very good connection, Matt. Are you walking away from the phone? We can't quite hear what you're saying.
No, I'm not.
Okay, try again. You're okay now.
Try again.
Just
works the pathway. And essentially, I've spent my whole career trying to improve the system we work within to ensure the pathway works best for patients. And we've had radical changes over the last few years to move from a very subjective, variable, and non-evidenced way of transferring patients' communication and what happens to them into one that is much more address ambulances and acute trusts to all move the same language of sickness news too. And the opportunity in our grasp is whether we choose to go down that route in all community settings as well to really unify what we do across the NHS at scale. Next slide. So I'm a firm believer that the community holds all of the answers, and that actually once one gets to the hospital setting, our fate is in some ways sealed. When you do proper analysis of all cases, deaths, and all cases of deaths in hospitals, what you realise is that only 3.6 to 3.7% of deaths in hospitals are probably or possibly preventable. And this flies in the face of our Health Secretary claims, and is obviously flies in the face of what Sepsis Trust and other well-meaning charities also claim. But the reality of this is the people that die in hospitals tend to be older patients with comorbidities, cancer, hospice-qualified patients, and actually there's a limit to what you can do with that substrate, and which is why we need to get the community elements as strong as possible. Next slide, please. We've set up an engagement forum, the National Deterioration Forum, which is based on the Futures NHS Collaboration Platform. I have made one key member of the Innovation Agency is a moderator, and I've set up an Innovation Agency sub, which means that you could actually use that across your whole region to actually communicate regularly with members and hopefully spur on some improvement. I've set up a forum for every single one of the 15 ASNs, and people are using it as they see fit to broadcast what is going on in each region, strategy plans, documents, and things like that. So far, the membership has grown exponentially, and we're up to 323 members so far. It's a very active forum for all the kind of questions we face on a daily basis. And within that, we are really answering some of the big questions in deterioration. So I urge you to use it and see how you go with it. Next slide, please. Next one, please. So those are some sample questions that have come up over the recent couple of weeks, but there's always a lot of action on that forum. Next slide, please. So what we're trying to do essentially is to align the way we manage sick people. It doesn't matter about the same principles and core standards need to be aligned. And what we're trying to achieve in the emergency department, a pilot that's going around 10 hospitals at the moment, is trying to marry our response to needs of 5 and 7 around those key directives. What I'm proposing is that we also have an inpatient sequence that matches that, and that's going through motions at the moment. We have nothing next, but I really hope we can have that to essentially cement what we're doing in hospitals to match what we're doing in the emergency department. The ambulances have a similar standard that revolves around an use of 7. In the future, I would love to see something in the community as well. It's all about aligning the same language and the same standards so there is no confusion. Next slide, please. So within our patient safety collaboratives and our HSNs, we have a terrific opportunity to collaborate at scale to ensure we try and innovate to answer the questions that face on us. And in my patch, the real thing that really brought us together was by our HSN that puts a commissioner, a paramedic, and a hospitalist on the same table, right, to actually make a resolution to try and do something differently, to try and think about the pathway as a whole. And that spurred on all of our movements to try and develop a standardised pathway for sickness across the region settings, and to work collaboratively on a project in all nursing and care homes, which actually bore out the fruit of Restore 2. Next slide, please. We had a strong belief that before you get sick, there is a prequel stage, which I termed soft sign just because I couldn't think of anything better. And what I meant by that was all those things that real people notice, who are notice, the change in normal behaviour and function of the ones that they love and they know. And what that generates a degree of concern. And then when you sort of anthropologically you track patients and what they really do when they feel ill or they are concerned, they talk to a friend. And then you have phone a friend situation, as in Who Wants to Be a Millionaire, and the 50-50 question where you are given advice by people you trust that eventually brings you to the attention of someone in the medical profession. Next slide, please. And then medical people look for these symptoms, these classic kind of core textbook symptoms. Next slide, please. In the case of sepsis infection, these ones. Next slide, please. Next slide, please. By the time you develop those symptoms, actually there's a limit to what you can do because it's a little bit on the too late stage. The question is, if you get to the symptoms at the point before serious pathology develops, can you prevent admission? Can you improve outcomes? Next stage, please. When we eventually carrying our physiology, usually it's at the point where it's time zero and the patient is probably in the hospital. So the question is, can you develop a that actually listens to what patients actually go through and responds to them before they develop deterioration and infection symptoms that eventually lead to an emergency admission stage? So these soft signs are kind of developed on the basis of work from Kellett, Bugvar and Bowser. So a bunch of nurses who've been studying this concept of nurse worry for some time. I coined the term soft signs thereafter. And I brought this down to those kind of metrics of dependency, transfers, walking, mobility, behaviour, and concern. We know that walking is an independent predictor of mortality, so it didn't seem a massive stretch to think about how we could objectify that in some form of score. Next slide, please. Next slide, please. So applying that to the learning disability population, we came up with a taxonomy of what those soft signs may be, and it's a bit complicated and busy, but these were what learning disabilities carers thought the important things in their clients. And it's a question of distilling a personalised checklist of what deterioration represented for each population. Next slide, please. So we take that to the front page. Next slide, please. And it becomes an intro into what it is you're noticing in your resident that is different to normal in a soft signs kind of capacity, because we recognise that not everyone has nursing or medical training. Next slide, please. Then you have the OBS chart itself, which please, which mirrors what we see in hospitals, and also contains a column for baseline, which is really not everyone is a zero. Next slide, please. And then when a resident deteriorates, an escalation plan is adding up that score and escalating as appropriate. Next slide, please. Together with a communication factor, because we found time and time again a big concern was people in nursing and care home environments potentially not having the confidence that exists within healthcare. It's very difficult if you're a more junior in a different silo to get the attention of a senior doctor, to get them to come and visit when you're genuinely worried about a patient. And this gives a framework for all of that, an ability to try and overcome that hierarchy and give confidence to those that need it, to make sure everyone is the same mental model of sickness. And we were very honoured to receive the National Award for Excellence in Primary Care in the recent Parliamentary Awards for this work. Next slide, please. When we crunch the data, we find that we're able to influence two main things: GP call-outs by about 25%, and 999 calls from care homes that implemented it, which dropped from between 15 and 36%. So impressive figures in terms of what a tool based around news to communication and soft signs of deterioration can accomplish at scale. Next slide, please. It also really put cat amongst the pigeons, because at the same time as this, we began a piece of work to analyse GP referrals and referrals from the community, and to validate the use of News2 across the entire care pathway. In response to the question from the community, quite rightly, as to whether there was any evidence up. So what we've done recently is prove that vital signs and News2 do predict outcomes when captured referral communicated. And the paper is under writing at the moment. Hopefully we'll get it up before the month. Based on a 25,000 patient study, my local organisation, all the care and nursing homes in the region, and all the GPs, and added services in the entire region as well. And as you can see, survivors have average news of about 2.7, and those who die have 5 to 6.7. So really crushes the idea that vital signs are not important in the community, and it crushes the idea that there is no validation for use too in community settings. This has gone to the RCGP as a paper and asking for mandatory implementation in the community. Next one. Yeah, sorry, I got confused with the graphic. But essentially, this is used as at different scores in general practice referral, as you can see. You hit 5, 13.6% mortality, 7, 24 points, greater than or equal to 9, 29%. It's just black and white. There is no, argument as to why we should be better at recording and transmitting that theology. And it's up to our hospitals to really ask the question. It's up to us as a community to ensure we give them the answer. Ambulance has already followed suit, so that when you're booking an ambulance care professional, you have to give the news score or you have to give the physiology. So the poor person, then phone you is the most urgent patient, actually has a framework for doing it. Because at the moment, good luck. Next slide, please. And in my patch, we will kind of apply that data to a format that we're going to work to as where we use a set number of news score to decide who can be managed in a kind of outpatient setting, who needs admission, what degree of monitoring they need. And that letter was written by patients, hopefully to move hearts and minds. Thank you very much. Any questions?
Thank you very much, Matt. That was a really fascinating presentation. I think from many perspectives, the data analysis was particularly powerful. Well, it's the same route as last time. So if anybody does have any questions, we've got a few minutes for questions, and those questions should be posted in the chat box. I think from my particular perspective, I guess what I like. Were there any concerns from the local system in terms of using the tool, whether that would actually increase hospital activity or that sort of thing? And if there were, how was that addressed?
So what we did was prove it with the data. So what always a concern, particularly from such practice, like a real meaning, that it's super apparent that if anything, reduce falls and the feedback from DVs, I loved it because suddenly instead of kind of massive communication getting an S before, which, to be honest, mirrors what we do in medicine. Doctors use SBAR without knowing they use SBAR. So to suddenly have professionals also using the same format was a massive. They had the information they needed to process decisions on whether they should come and visit a resident in a nursing or care environment, and they saw the value in that. So we got a body of GPs that right behind it really supported it.
I mean, that's my next question, really. I mean, in terms of the level of support amongst GPs and other members of the primary care system, was that something that essentially has grown, or was that what's the position there in terms of the general level of support?
Yeah, well, I tell you what, it basically spurred the GPs on to look at what news was, because playing catch up, our nursing home and care home colleagues did a fantastic job. They really avidly did this. It gave them a voice. It gave them a seat at the table. It gave them a place that was beyond their customary hierarchy. They could challenge, complain, and issue their concerns in a medicalised format. So it forced our GPs to really up the game. It forced just nurses to up the game. It probably forced receptionists to up the game as well in terms of clarity of the conversation. And the whole system has benefited.
Yeah, that's incredible. Phil, are there any other questions that have been placed for Matt at all?
No, there's no questions in the chat box for Matt at the moment.
Got another minute or so. We'll just give that maybe 30 seconds. And
can I voice a final plea for you?
do.
Do you have a mix? Hello? Can you hear me?
Sorry, I'm not hearing that at all.
Hello? Can you hear me? Yeah. So my question is just whether you've got a mix of people in the community.
Can we answer that, Phil? Have we got a mix on the call today?
Okay. I mean, cause
yeah. Sorry, go on.
one of the key things is, you know, certainly in my hospital, one of the key things was the generosity of my consultant colleagues and colleagues in acute care generally to develop and support systems where we requested that physiology at referral points. Because as soon as you start getting the language through and the message of how sick someone is before they arrive as an admission, you have safe patients. You have people that don't end up in the wrong area with really bad pathology and physiology. And those are the people that have cardiac arrest. My pitch would be to work collaboratively, encourage that transmission of that new score recording at all places of care, particularly referral from the community to the hospital, and measuring those outcomes. It takes long for you to prove it makes a difference. And you need local proof to really move hearts and minds.
Yeah. And obviously as well, where we've had successes elsewhere and we can profess those successes, you know, in our various localities, and that's obviously a very important message as well.
Yeah, great.
We've had a question come through for you, Matt. It's when you say that you're asking for News 2 to be mandated, who would this include?
Sorry, you're talking about general practice? Or
Is that
all ambulances and hospitals?
Not sure.
It is mandated ambulances and all acute hospitals by the national contract, the quality contract this year. The general practice element is that it hasn't been mandated, but there's a paper that's gone to RCGP to get their support. So we don't have an answer yet, but you know, hopefully they're going to see the light.
Okay, thank you. Ian, I think we're about out of time, so do you want to...
Okay, well, certainly. Thank you again, Matt, for that fascinating presentation, and thanks, Phil. So, as there are no further questions, I think that probably concludes our big innovation conversation today. Thank you all for joining and contributing and listening. And again, another special thanks to both Jane and Matt for sharing their work today. So thanks again to you all, and do enjoy the rest of your day. And it's 13:31, so good time. Thanks again.